Welcome to the Migraine Treatment Guide podcast, where we explore what really causes chronic migraines and headaches and the full range of treatments available today. Each episode breaks down the medical research and real patient experiences to help those living with chronic head pain understand their options and find a path toward lasting relief.
Every single year in the United States, there are nearly 1.7 million traumatic brain injuries.
Yeah, which is just a staggering number when you really stop to think about it.
Right. I mean, we're talking about a massive portion of the population going through some kind of violent physical impact to the head or neck.
Absolutely. You've got sports collisions, slip and falls, endless rear-end car accidents.
Endless.
Yeah.
And if you actually dig into the medical data after all of those impacts, the single most common complaint people have afterward is, you guessed it, a headache.
Right, which makes total sense initially.
Exactly, it makes sense. And for a lot of folks, that pain slowly fades as their body heals. But there's this massive subset of people whose headache just never leaves.
It doesn't fade at all?
No, it becomes persistent. It becomes completely debilitating, and it can literally hijack your life for years. And the really strange thing is that the symptoms almost exactly mimic a traditional severe migraine.
They do. The symptoms are so identical to chemical migraines that patients enter this incredibly frustrating cycle of misdiagnosis.
Oh, I bet.
Yeah, they sit in a doctor's office, and the initial trauma, the car crash or the fall, is years in the rearview mirror, yet they're still experiencing this intense, throbbing pain.
Which is just awful.
Yeah.
So our mission for this deep dive is to figure out why these specific post-traumatic headaches linger for decades. Like, why are they so notoriously misdiagnosed?
And more importantly, how modern medicine is finally uncovering a physical, mechanical way to stop them.
Yes, exactly. So
Yeah.
whether you're an athlete who took a hard hit in college, or someone dealing with the lingering effects of a minor fender bender, or, you're just insanely curious about medical mysteries, this is going to fundamentally change how you think about pain.
It really is a paradigm shift.
It is. And our guide today is a comprehensive educational document by Dr. Adam Lowenstein from the Migraine Surgery Specialty Center in Santa Barbara, California. You can find them at headachesurgery.com. They focus on post-traumatic headaches and a very specific anatomical structure called the greater occipital nerve.
What's fascinating here is the core plot twist of this entire medical mystery. When you go into a clinic complaining of a severe chronic headache after a head injury, the natural assumption from you, the patient, and frequently the medical staff, is that the source of the pain is located inside the skull.
Right. Because your head hurts. So you assume, I hit my head, my brain is hurt.
Exactly. The assumption is brain trauma. But the clinical research we are looking at points to a completely different culprit. A very large share of these post-traumatic headaches actually trace back not to the brain, but to the soft tissue of the neck.
Wait, really? So you hit your head hurts for 10 years, and the source of the fire is actually hiding down in your neck.
That is exactly what's happening. And to wrap our minds around how that pain originates down there, we really need to break down the sheer physical violence of a head or neck injury.
Okay.
We need to look at the anatomy of a crash.
Let's do it. Where do we start?
We have to look at the structural engineering of the human body, specifically the pathway of that nerve we mentioned, the greater occipital nerve.
Right, the GON.
Yeah, the GON. This nerve is the central character in all the documentation. It emerges near the very top of your cervical spine.
Okay, top of the spine.
But to do its job, it has to travel upward to reach the skin of your scalp. And it does not have a clear, hollow tube to travel through.
It doesn't just get a free highway.
Not at all. It has to weave its way upward through several dense, heavy layers of neck muscle, specifically the splenius capatus and the trapezius muscles.
Wow.
And then, after navigating through all those thick muscle bellies, it finally has to pierce through a very tough layer of connective tissue, the fascia, right at the base of the skull before it can spread out across the back of the head.
Man, so it has to thread a needle through some incredibly dense, heavy-duty machinery just to get to the surface.
Exactly, and those specific muscles act as the body's primary dynamic stabilizing system for your head.
Because the head is heavy, right?
Very heavy. The average human skull is roughly the weight of a bowling ball. So when you experience a sudden impact, like a severe whiplash event, that heavy bowling ball wants to keep moving violently in whatever direction physical momentum is taking it.
Physics 101. An object in motion stays in motion. The physics of a car crash dictate that your head is going to keep flying forward even after the car stops.
Exactly. But to prevent that heavy skull from simply snapping your cervical spine, those thick neck muscles instantly contract.
Oh, wow.
Yeah, they fire forcefully and rapidly to act as your body's emergency brakes. They are forced to absorb massive amounts of kinetic energy to keep the head from moving past its structural limits.
I mean, that's a brilliant automatic life-saving response from the body.
It is life-saving, yes. But it causes immense structural strain and trauma to the tissue itself. And remember where the greater occipital nerve is.
Oh, right. It's running directly through those exact muscles.
It runs directly through the exact muscle bellies that are absorbing all that violent, extreme force.
Okay, let's unpack this for a second. It's basically like running a delicate, highly sensitive power cable straight through the mechanical gears of a car's emergency brake.
That's a great way to picture it.
Right. When the brake slams on, that cable is caught directly in the crush zone.
It really is. The whiplash force pulls the skull one way, and the muscles violently pull the other way. The nerve gets yanked and compressed simultaneously.
Yeah, I think anyone who has ever had whiplash remembers that horrible, stiff, radiating pain in the days immediately following the accident.
Definitely.
But I'm kind of struggling with the math here. I understand the nerve gets crushed during the actual impact. But bodies heal.
They do.
Like, if I pull my hamstring in a sprint, it hurts, I limp around, and a month later I'm fine. How does a tweaked neck in a minor collision turn into a decade of debilitating migraine-level pain?
That's the million-dollar question. We have to look at how the human body repairs soft tissue trauma because it doesn't always repair it perfectly. Your hamstring analogy is actually perfect because it is the exact same type of physiological injury.
But a pulled hamstring heals. Why doesn't this?
It comes down to how the healing environment is managed. Think about the sports world.
Okay.
When a professional athlete pulls a muscle, what happens? They immediately begin targeted physical therapy. They undergo deep tissue massage.
Right. They have a whole team working on them.
Exactly. Professionals are actively manipulating and re-stretching that healing tissue day after day. The entire goal of that therapy is to guide the newly forming cells so that as the muscle fibers knit back together, they heal in parallel, pliable lines.
Instead of just clumping up.
Right. They want to prevent it from forming a disorganized, permanent knot of rigid scar tissue.
And the person who gets rear-ended at a stoplight and goes to the ER is definitely not getting a professional athletic trainer assigned to manage their neck muscles for the next month.
Not even close. They are sent home with instructions to rest, maybe take some over-the-counter pain relievers, and, just wait for the soreness to fade.
So the soft tissue in their neck is completely ignored.
Completely ignored during the most crucial window of cellular repair. And because the tissue isn't being actively guided, stretched, and manipulated, the body takes the fastest route possible. It lays down dense, chaotic fibers of scar tissue.
And scar tissue is fundamentally different material than healthy original muscle tissue.
It behaves completely differently. Healthy muscle and healthy fascia are pliable. They stretch, they glide over each other, they expand and contract dynamically.
Right.
But once scar tissue matures over several months, it becomes dense, fibrous, and largely fixed in place. It loses all of its natural elasticity, and because that micro-tearing happened deep inside the muscle, right next to the greater occipital nerve or the nearby third and lesser occipital nerves, the body essentially builds a tight, rigid ring of non-stretching scar tissue directly around the nerve itself.
Man. So what does this all mean for the patient's actual experience? Like, we aren't talking about the dull ache of a healing bruise anymore. We are talking about a permanent physical vice grip on the nerve, right?
Exactly. The condition transitions from an acute muscular injury to a chronic mechanical nerve compression. This is why the pain pattern changes so drastically.
Okay, that makes sense.
In the weeks following the crash, you have that diffuse, widespread neck soreness. It's a tender muscle. But as that scar tissue hardens and matures, which can take months or even years, it begins applying constant, unyielding mechanical pressure to the nerve.
It's just squeezing it.
Squeezing it constantly. So the patient starts experiencing persistent, localized, sharp, or throbbing pain, usually radiating from the back of the neck up over the scalp. The muscle ache is gone. What remains is a suffocated nerve firing nonstop distress signals into the head.
It's firing those signals directly into the central nervous system, which then interprets that massive influx of pain data and manifests it as what feels exactly like a severe migraine.
Exactly.
But wait, if I have a literal vice grip made of scar tissue choking a nerve in my neck, Why doesn't an ER doctor just look at a scan and see the pinched nerve? Why are people suffering for 15 years without anyone pointing to the screen and saying, there's the problem?
Well, we have to understand what standard medical scans are calibrated to find, particularly in a trauma setting. When you hit your head in a car crash and develop an immediate severe headache, emergency room evaluation is non-negotiable.
Right, obviously.
The medical team's primary job in that moment is to keep you alive.
They need to make sure your skull isn't fractured and you aren't bleeding into your brain cavity.
Exactly. So they will run a CT scan or an MRI to rule out life-threatening acute injuries like intracranial hemorrhaging. Those imaging machines are brilliantly designed to find dense bone breaks or pools of blood.
Okay, so they're looking for the big, immediate killers.
Right. Once a brain bleed is ruled out, the ER doctor will look at the patient and deliver what sounds like good news. Your scan is completely normal.
Your scan is normal, but the patient is sitting there feeling like their head is splitting open.
Yeah, and this is the diagnostic blind spot that traps so many patients. Emergency imaging techniques were never built to detect microscopic fibrous scar tissue compressing a peripheral nerve deep inside a muscle belly.
Really? So it just doesn't show up?
Right. Strained, thickened fascia does not light up on a standard MRI as a flashing red danger zone. It simply blends in with the surrounding soft tissue on the readout.
Wow. So the patient gets sent home. They told they don't have a brain injury. Their scans are clean, but the chronic head pain eventually sets in.
And then the cycle begins.
Right. They visit a neurologist. They describe symptoms that sound exactly like migraines, and they are handed chemical migraine medication.
Yeah.
But that medication barely takes the edge off because it is designed to treat a neurological chemical imbalance in the brain, not a physical piece of scar tissue crushing a nerve in the neck.
To compound the difficulty, the timeline totally masks the true cause. Patients rarely connect their current daily head pain to a minor whiplash event that occurred, say, 3 years prior.
Oh, because there was a gap.
Exactly. The acute soreness of the initial crash faded, they experienced a symptom-free gap, and then the chronic headaches slowly ramped up as the internal scar tissue matured and tightened. They view them as two entirely unrelated chapters of their medical history.
That is so frustrating.
Yeah.
But if the MRI is effectively blind to this scar tissue, how does a specialist actually prove that this mechanical compression is the root cause?
Right.
How do we find a vice grip we literally can't see?
The diagnostic solution bypasses imaging entirely and relies on a practical intervention, symptom mapping combined with a diagnostic nerve block.
A nerve block.
Okay.
Yeah.
A specialist will inject a targeted numbing agent, a local anesthetic, directly into the specific anatomical area where the greater occipital nerve pierces the muscle.
So it's less about fixing the tissue in that moment and more about chemically cutting the communication wire so the distress signal temporarily never reaches the brain.
Exactly. The anesthetic temporarily blocks the nerve's ability to transmit any signals.
Gotcha.
If the patient has been suffering from a debilitating level-9 headache and that targeted nerve block produces profound immediate relief while the numbing agent is active, it proves the physiological concept.
That is wild.
Right. It confirms that the pain is being driven by peripheral compression of that specific nerve pathway in the neck, rather than an ongoing neurological disease deep inside the brain.
You know, here's where it gets really interesting. There is a specific diagnostic sequencing rule mentioned in our sources. Doctors evaluating chronic neck and head pain are advised to perform this simple, temporary occipital nerve block before they even consider recommending something as drastic as cervical spine surgery. It acts as this vital, low-risk checkpoint.
It's so important because skipping that checkpoint can lead to devastating surgical outcomes.
Oh, I can imagine.
Imagine undergoing highly invasive, permanent spinal fusion surgery to cure severe post-traumatic head pain. You go through months of brutal recovery only to realize the pain is still there.
Ugh, horrifying.
The spinal surgery failed because the actual problem was just a tiny knot of dense scar tissue squeezing a peripheral nerve an inch away from the spine. The diagnostic block verifies the exact location of the hardware problem before anyone picks up a scalpel.
A hardware problem as opposed to a software bug in the brain. I like that. Okay, so the diagnostic block confirms the wire is physically pinched.
Yes.
But how do we actually unpinch it? Because the numbing agent wears off eventually. What is the permanent fix?
Once the diagnostic block confirms that scarred or thickened fascia is the culprit, the long-term treatment shifts to a mechanical solution for a mechanical problem. The procedure is called surgical nerve decompression and scar tissue release.
Okay, I want to be very clear about this for anyone listening. When people hear nerve block or release, they often think of a quick, 10-minute visit to an outpatient clinic. This decompression is an actual formal surgery, correct?
Right. This is a real surgical operation. It's performed under sedation or general anesthesia by a highly trained peripheral nerve surgeon. It is not an office procedure under local anesthetic.
Right. So what actually happens in the operating room?
During the operation, the surgeon makes an incision to carefully expose the exact pathway of the greater occipital nerve. They physically locate those restrictive bands of scar tissue and the unnaturally tight fascia.
They can actually see it.
Yes.
Mhm.
And using surgical instruments, they carefully release those strictures. They cut away the tension, physically freeing the nerve from the vise grip. The goal is to create permanent space around the nerve so that the mechanical compression is eliminated entirely. And, depending on the trauma, the surgeon can evaluate and decompress the greater, the lesser, and the third occipital nerves all during the same operation.
That is incredible. And, the documentation from headachesurgery.com includes a gallery of intraoperative photographs showing this exact mechanism.
The photos are really something.
Yeah, they really are. Obviously, they are surgical photos, so they're pretty graphic. But the visual evidence of what is happening inside the neck is just striking.
What stands out to you in them?
Well, in the before picture, you can literally see the greater occipital nerve looking indented, constricted, and almost strangled by this thick, white, fibrous band of tissue.
Yes.
Then the after picture, immediately following the surgeon cutting that tissue away, the nerve visually transforms. It becomes plump, pink, and well perfused. You can literally see the blood flow returning to the tissue in real time.
And that visible return of blood flow is the physiological core of the procedure's success. The restrictive tissue wasn't just sending pain signals, it was literally choking off the microscopic blood vessels that feed the nerve itself.
So it was starving the nerve.
Exactly. When you remove the physical blockage, normal vascular function and nerve signaling can finally stabilize.
The source material highlights a specific case study that genuinely shocked me. They detail a patient who had been suffering from severe, debilitating migraines for over 15 years.
15 years. It's hard to even fathom.
15 years of losing days at a time to dark rooms and heavy pain medication. But when the surgical team finally went in to perform the decompression, they discovered that her trapezius fascia, the connective tissue layer sitting right on top of the muscle, had thickened to over 1 centimeter.
Which is just wild. A full centimeter of thickened fascia is a massive physiological abnormality. Healthy fascia is thin. It's almost translucent.
Right. A centimeter of dense tissue pressing directly on a sensory nerve for a decade and a half. It really hammers home that this isn't some mysterious software bug in the brain, but a very fixable hardware problem in the neck.
Absolutely.
And the documents emphasize that this case isn't just a random anomaly. They cite supporting research from Harvard demonstrating that patients suffering from chronic headaches actually possess measurably thicker trapezius fascia than people without a history of headaches.
The Harvard research is a crucial piece of the puzzle here. By using advanced ultrasound techniques to measure the actual thickness of the fascia in different populations, they provided objective, measurable proof that this thickened tissue correlates directly with chronic pain.
It's hard proof.
Yes, it completely validates the entire surgical concept. The thick, scarred fascia is a genuine mechanical cause of the nerve compression, not just some incidental finding.
Okay, so we have the anatomical theory, we have the diagnostic blocks, and we have the physical evidence from the operating table. The final question is, when a surgeon actually cuts away that centimeter of fascia, does the headache actually stop? What do the real-world outcomes look like?
The clinical data is highly compelling. The Migraine Surgery Specialty Center publishes their own outcome metrics, reporting a success rate of 93% overall for their evaluated and treated chronic migraine patients.
93%.
Yeah. And when isolating for appropriately selected post-traumatic candidates, people whose pain started after specific injury, the success rate remains greater than 90%.
Man, for patients who have spent years being told their condition is a chronic, unfixable neurological disease they just have to learn to live with, a 90% success rate is life-altering.
It is a massive paradigm shift for the patient. And we see these positive outcomes reflected in the broader scientific literature beyond just one specialized clinic, too.
Oh, really? Like what?
Well, a prime example is a 2021 retrospective cohort study published in the peer-reviewed journal Acta Neurochirurgica by a researcher named Eskilsson and their colleagues.
Okay.
They specifically tracked patients undergoing decompression of the greater occipital nerve. The study found that 77% of the patients experienced significant improvement in their chronic headache or neck pain following the surgical release.
That's huge.
It is. And the authors of that study explicitly noted that the diagnostic occipital nerve block is a highly reliable, established tool for isolating and diagnosing headaches that develop following head trauma and whiplash.
It's amazing how the evidence converges from every single angle. The physics of the crash explain the injury. The biology of scar tissue explains the delayed chronic pain.
Yep.
The limitations of emergency MRIs explain the years of misdiagnosis. And the long-term outcome data from both private clinics and international peer-reviewed journals confirm that mechanically cutting the nerve free produces real, lasting relief. It literally takes patients out of the dark.
It does. And if we connect this to the bigger picture, it changes how you should advocate for your own health.
Right, because you have to be your own advocate.
Exactly. It teaches you a fundamental lesson about the inherent limitations of our standard diagnostic tools. Just because a state-of-the-art MRI machine reads your scan as normal, it does not mean your pain isn't real or mechanical.
It just means the machine isn't looking for it.
Right. It simply means the machine isn't built for the type of microscopic soft tissue compression that might be causing it. You know your own body's history. If years of chemical treatments and migraine pills aren't moving the needle, the underlying issue might be structural.
We've learned today that our body's brilliant automatic healing mechanism, deploying a web of scar tissue to rapidly patch up microscopic trauma, can actually turn into a permanent trap if it isn't guided properly.
It's a double-edged sword.
It really is. The life-saving emergency brake engages, but the release cable snaps, leaving the tension locked in place for decades. It really makes you wonder how many other unexplainable chronic pains in completely different parts of our bodies are actually just our own protective internal armor that simply forgot to let go.
That's all for today's episode. Thank you for listening. If you or someone you love is living with chronic headaches or migraines and hasn't found relief through medication or other treatments, know that outpatient surgical options exist for chronic migraine, occipital neuralgia, and other headache diagnoses. To learn more or schedule a consultation, call Dr. Lowenstein's office at 805-969-9004 or visit headachesurgery.com. Please don't forget to rate our podcasts so others can find us and learn about chronic headache relief options. Thanks again for tuning in, and we'll see you next time.